system that they created was an employer-employee-based healthcare system. The employer and the employee contributed money, like many of us in the United States currently still do. The employer and the employee contributed money and paid doctors and hospitals privately. This is called the Bismarck model, a privatized healthcare system. Okay? Versus a system developed by a guy named Beveridge. Spelling is just a little different, and it's not a liquid. Okay? Beveridge, who was English. So now we're going to fast forward to the 1940s, and Beveridge comes out in 1942 and proposes the creation of a welfare state in Britain. And you have, after World War II is over, ironically, Winston Churchill, for all of the huge successes that he has in saving England from total destruction by the Nazis, he is tossed out. Labor government comes in, and what do? They create the British healthcare system, which we'll talk about more in a minute. It is a universal healthcare system owned by the government, not private. Now, why did they do this in the UK, in Great Britain, in 1945? Who threatened them? What was the threat? What was the threat? I got it right here. Communism. The Iron Curtain is, that's right, and that's Churchill. It talks about the Iron Curtain. And communism is a huge threat to all of Europe. The United States doesn't care about communism. Well, it cares about communism, but its response to the threat is different. The response to the threat in the United States is to build nuclear weapons and to say to the communists, you mess with us, you're gone. Okay? Right? In Europe, what they did was they tried to accommodate some of the communist beliefs, just like Bismarck did. Okay? So Beveridge says, let's create a healthcare system that we will do as our own country, and we'll show the communists, we'll actually show the British people that you don't need to be a communist to do it. Okay? We in England and in the UK will do this. Interestingly, because the UK is a pretty capitalist country, okay? I mean, it is not the same social welfare state that you see, let's say, in Sweden, okay? But in 1945, under the threat of communism, they created a whole new healthcare system in the UK that was a truly socialized healthcare system. And the British continue to have it, and we'll go over it in just a moment, okay? So you have two models, the Bismarck model and the Beveridge model of health systems. The Bismarck model is basically a privatized model, okay? You pay privately, you get health care through a relatively private system. What we used to have in the United States would be called, like the Blue Cross Blue Shield system, or United Healthcare today, or Aetna, okay, right? An employer would play a pretty big role. The Beveridge system of healthcare, which is, as we'll see in a number of countries, is government owns and runs it all, more or less, okay? So let's go to these, yes sir?
The Bismarck, I thought that even though it was private, well, no, you said Britain was owned by the government and
right.
Bismarck, but
right.
I thought that even though they were buying it privately, that the prices and doctors were regulated.
Okay, you're right. This is both, right? Yeah. So what the Bismarck model does is the government's involved.
It's
they
involved.
Just don't own it. The government sets it up, it rules, it sets the rules, it may set the prices. It's, in some cases, responsible for quality, okay? But the government doesn't own it. Government regulates it. Okay. All right, so now we're going to go through, we're going to look at 4 countries as models, okay? The first is the UK, United Kingdom or Great Britain, okay? And I use the terms United Kingdom and Great Britain pretty liberally. There are differences, and I can't tell you what they are. I don't remember. Anybody tell us? Anybody know? As it pertains to the health system, actually, the English have a slightly different healthcare system than the Scots do, for example. Okay, and I don't know where the Welsh are. They're in there as well. I think there are slightly different systems. I'm lumping it all together because, for our purposes, they're very, very similar. Okay. Okay. So as we look at these four countries, we're going to ask the questions on the left. Who's covered? Who regulates this system? Who owns the hospitals, the doctors, the clinics, and the whole system? Who pays? And how expensive is it? Okay? So we're going to look at all of these. As I said to you, in the UK, everyone is covered. It's a universal healthcare system. The government regulates the whole thing. Interestingly enough, in the politics of Great Britain, every so often people start talking about the National Health Service, which is what it's called, the NHS. And they say, oh, it's too expensive, it's not good enough, it's this and this. One of the prime ministers back now about 10 years ago said, fine, we're going to fix, if you elect me, and he was a Tory, he was a conservative, you elect me, we're going to really fix the National Health Service. He gets elected, he says, we're going to do this, this, and this, we're going to save money, we're going to control this and that. And the public had an absolute furor. He almost lost his position. Okay? Because the public loves this. The British love this system. Even though, as we'll see, we could criticize it. Okay? So let's talk about what it is, and then we'll talk about its criticism a little bit. Okay, so who is covered? Everyone is covered. Who regulates it? The government. Who owns the hospitals? The government. Yes, sir.
So actually, could you please define what you mean by regulate? So by regulate, you mean who determines where the money goes, or do you mean by regulate who determines which medical procedure is appropriate for which disease? So who decides, as somebody was saying back here, who says who's going to get a knee replacement?
Yeah.
Or do you mean or are you saying the government says this year we'll pay $1,100 for a knee replacement, or or for cataract?
Yeah. Okay. So in the UK, like in Sweden, Norway, Denmark, Scandinavian countries, the government does all of it. So the government says, we will pay X number of pounds for this service. This service is covered. This service is not covered. This drug is available. This drug is not available. Okay? They have an organization that has an acronym which is called NICE, N-I-C-E. And NICE decides whether a new drug is covered, whether a procedure is covered. Okay? So, for example, about 20 years ago, some researchers started doing bone marrow transplants for women with advanced breast cancer. And there was a belief at one point in time that it really worked. And then more science came out, it doesn't work. Okay? Well, in the United States, if you want a bone marrow transplant for breast cancer, somebody will probably do it. Okay? In the UK, you can't get it done. Not going to happen. It's against the law. Okay? Yeah.
So you're saying it's against the law because epidemiological research and medical science shows that it simply doesn't work, or in fact the outcomes are worse than they would be if you didn't.
Right.
If you didn't do it.
Yes, and the NICE panel has ruled that.
Okay. So that's
whereas in other countries, you want it, maybe you'll pay for it, maybe the insurance company will give it to you. So they control everything. Government decides everything. I'm simplifying it by saying government. You're going to have government agencies and government consuls and this, but it's basically a government function. Okay? The doctors work for the government. It's not clear to me if they're actually employees or if they're individual practitioners, but for all intents and purposes, they are employees of the government. The government sets the fees, tells them how many patients they see every hour, tells them how many people they can employ. They probably, I don't even know that they employ their own people. I don't think so. I think they all work for the government. It's possible that the National Health Service is the biggest single employer anywhere in the world. There are just hundreds of thousands of employees in the National Health Service. And the government owns the clinics, the government owns the entire system. And it's all paid for with taxes, plain and simple. Okay, you pay your taxes, it goes into that system. Okay? And it's relatively cheap. So in the United States, we're going to get to this. I think that we're a few more slides. I think it's $10,000 per person per year is the average healthcare cost today. It's $4,000 in the UK. 4,000, less than half, right? In an advanced society, okay? Now, what do they get for it? Well, their life expectancy is 81.2, and on a rank of the wealthiest countries in the world, that comes out as number 22. So do the British pay a price for their universal health care and limited cost? They do. You just don't get stuff in the UK that you would get other places. I know at one point, at a certain age, you were no longer eligible for dialysis. It was either 75 or 80, okay, which is not, most of us in this room, not old, okay, right? But in the UK, if you were on dialysis, either, and I can't remember, either it would be stopped at that age, or you just wouldn't get it if you needed it, if you needed it started after that age, okay? Well, in the United States, you can be 120 and get dialysis. There's no limit, and if someone tries to limit it, you're going to go to court to stop it, okay? So the UK has a system that's efficient, but it's on the low side of cost, and there are consequences of that from a health perspective. Okay. Now, we're going to go to Switzerland. Anybody been to Switzerland? I assume some people have. What's it like?
Beautiful and rich.
Beautiful and rich, okay?
Clean and white.
Clean and white, okay? And they've got a great healthcare system. The average life expectancy, this is from 2017, so it's 83.3. And I've simplified it. Ladies, you do know that you live 2 to 3 years longer than us guys do, okay? Right? So you can do your planning and figure that out. We'll be gone, so don't worry about it, okay? Fellas, you don't have to worry. But the average, I'm giving you the averages, men and women, okay? All right, so who's covered? In Switzerland, everyone is covered. Universal health care in Switzerland, okay? Who regulates it? The government. Government sets the prices. Government regulates the kind of care people get. But the ownership is all privatized, okay? People have health insurance, like many of us in the United States, okay? Good old-fashioned health insurance. There are 80 health insurance companies in Switzerland. They all compete with each other. You pay your premium. Most of it is employer-based, employer-employee-based, okay? Now, what happens to people who aren't working, unemployed, disabled, elderly, retired? The government picks up and pays the cost of their health care. How can Switzerland get away with it? Well, we've heard already. It's rich. It's a rich country. They can afford it. And there aren't many poor people. And they don't have many immigrants. Right? They've created this nice little world for themselves where by declaring themselves as neutral, they don't have responsibility for dealing with refugees or dealing with, they don't import people, and the people they have, they take care of. So it's a system that works very successfully. It's relatively expensive, right? So let's just go back for a second. The British are paying $4,000 per year, and the Swiss are paying virtually twice that for their health care. It's an expensive healthcare system. Okay? Questions from anybody about the Swiss system? Yes, sir.
What about taxes, the rate of taxes in these countries?
Okay, in Western Europe, taxes are relatively high. Okay? In Switzerland specifically, I actually don't know. I'm going to guess that they're not as high as they would be, let's say, in Sweden. but they're gonna be fairly high.
I thought England was pretty high, 90-something percent or something, I don't know, over a certain
I
amount.
think the English pay quite a lot of taxes. I do. I don't know exactly what the rate is.
I just think that's a factor, you know.
Absolutely it is. Yep. Glenda?
You mentioned that, the government pays for the poor elderly. Is that through health insurance? Do they have health insurance that they pay for, or is it?
I think so.
cost?
I can't remember exactly, but I believe that the government probably pays insurance companies, pays the cost of the premiums for people. Now, it's possible there's a government plan just for this subgroup of people. Yes, ma'am?
I have a good friend she's British, but they live in Canada, they have dual citizenship, and so back and forth, parents still lived in England. She indicated to me, she's in the medical field, she indicated to me that they still could buy a private health insurance plan. And so if they wanted something beyond the
Okay.
government.
Okay, so I've oversimplified.
Oh, no,
this,
okay, I don't mean
Yes,
complicated.
and this is fascinating for me. In the UK, you can get private health insurance. And who gets it? Like 1% of the population,
Right.
okay? Which is very interesting. So their social structure, even the rich people, use the National Health Service. Only this very small, the
If
1%.
you want something beyond what the government is like the dialysis you
Right.
mentioned, they
Right.
still could.
There is a way to do it.
Way.
In many countries, they have this, it is sort of like a steam valve, okay? So that if somebody really wants it, you can say, fine, you want it, you can pay for it, okay? Right. Yes, ma'am.
So what are the regulations on who gets the surgeries in Switzerland? The elderly? who
It's
are-
gonna be much more liberal than it is in the UK. Yeah, you can pretty much, because it's all privatized, okay? And the government's gonna make sure it's fair, but it's not gonna have much influence on what drugs are available, so you're gonna have more drugs available, okay, for example, okay? And more treatments, and if you, and your doctor's gonna have more freedom to make their own decisions, okay? So if you go to look at something like hip replacement, there are all sorts of different appliances that are available, and in some countries, like the US, the orthopedist is going to choose what appliance, what company what vendor they want to use, okay? And you may have, and it's very expensive, so let's say at Athens Regional, maybe there are 10 different vendors who supply these artificial hips. Well, that's expensive because each one is different, long story, right? In the UK, maybe there are 3, okay? In Switzerland, there are probably gonna be as many as there are here. Bob?
Yes, in Switzerland, does everybody get the same services, or does it depend on what insurance program you have?
Yes and yes, okay. So I think the government regulates the insurance companies relatively tightly, but they're still competing with each other. So they have to say, we're better, insurance company A is better than insurance company B. They must offer some things that are different. A lot of times what happens is people get the minimum coverage guaranteed to them, and it's the trimmings that make a difference. So do you get a private room or do you get a semi-private room, okay? Do you get to see the doctor today, or do you have to wait 3 days to see him? Okay, stuff like that. All right, one last reference, I want to thank Daphne Raz, who's a student of mine, just graduated in Haifa with her Master's of Public Health. She provided some of the information that I'm using for the discussion of Switzerland, okay? She deserves credit. She's also a lovely person, but that's another story. Okay, on to France. So I started actually looking at health systems about 20 years ago, and the World Health Organization studied health systems around the world, and they ranked them. And this report came out in the year 2000. It was very controversial, and France came out ranked as #1 best healthcare system in the world. The United States, anybody heard of this study? I've talked about it at the last one of my presentations. United States came out, what would you guess? There are about 200 countries in the world.
About 170.
90?
37. It was infamous for the United States. And the irony was that the United States paid for most of the study. So it's probably not going to be repeated. Okay. France came out as number one. So I got interested, and while my colleagues in global health were running around in Africa, I went to Paris for a week. Okay? I said, I've got to study the French healthcare system. I didn't mess up. Okay? Life expectancy in France, 82.9, fifth best among the wealthy countries, fifth best in the world. So it's very good. Who's covered? Everyone is covered. Turns out, of all the high-income countries in the world, there is only one that does not cover everyone. That's the United States of America. Everyone else, all these high-income countries cover everyone. Okay? Who regulates it? The government regulates healthcare in France. Okay? Who owns it? This is complicated. Okay? So let's go back to Switzerland for one moment just to make a point. This is a Bismarck model. It's privatized. Government regulates it, everyone's covered, but it's really a private system of care in Switzerland. Okay? In France, it's a mixed model. It's kind of halfway between Bismarck and Beveridge. I guess they didn't read the books. Because they developed a system that wasn't classically one way or the other. So the government plays a pretty big role in regulating healthcare. The hospitals are owned locally, but they're owned by the government. So they'd be like Athens Regional or even St. Mary's to some degree, okay? Owned by the government, not for profit. I mean, here they're not for profit. They aren't owned by the government. But they're owned locally and controlled locally. The doctors, interesting story with the doctors. Some are paid a salary and some are fee for service. Okay, so let's just talk about the impact of doctor payment on healthcare practice. So when I was in private practice in Rochester, New York, I was paid fee for service. What did that mean? What does that mean?
There was a set fee schedule that was followed in terms of your reimbursement for whatever happened to be.
When I started in 1980, I set my own fees. By 1985, the insurance companies and Medicare were setting my fees for me. Now, how did I make the income that I made?
Saw more people.
Saw more people. It's a volume-based system. The more people I saw, the more money I made. My incentive, therefore, is quick, volume.
Meet 'em, greet 'em, street 'em.
Meet 'em, greet 'em, and street 'em. Yes, sir.
Well, you could have also seen patients who were sicker because you were paid at a higher rate, or presumably you should have been paid at a higher rate for seeing patients who required a greater intensity of service.
Yeah, and more or less that wasn't the case. And more or less it still sort of isn't, okay? Which is a problem. It's a problem in the fee-for-service world. You would think you should get paid more if you've got a more complicated situation. And it kind of is, but not much, okay? And most people in a fee-for-service world are incentivized for volume. Now let's talk about the impact that this has. Let's pick a cardiologist, okay? I don't have any cardiologists in my picture, so I can pick up. Yeah, that's good, okay? So you go to the cardiologist and you say, I've had chest pain for the last 3 months. And that cardiologist has a decision to make. What's that decision going to make? What be?
Heart cath.
Do I do a heart cath or not? What's the financial consequence of that decision to the cardiologist?
It's significant.
Significant, right. If I say,
A self-referral.
Sure, yeah, because he or she is going to get paid, I don't know, $1,500 or something like that to do that procedure. If they decide you don't need it, what are they going to get paid? $100 for the office visit? Maybe they'll see you again, maybe $200, yes, sir.
Oh, and there's a chance you'll get sued.
And you could get sued, which
You can get sued if something happens to a man and you didn't do the right test or the right
Right.
treatment.
Now, you could get sued either way, right? So if you tell somebody they need a procedure that they don't need and something goes wrong, you can get sued.
Right.
If you tell them they don't need it and they needed it, you can get sued, okay?
Mhm.
Right? But let's just go back to the volume incentive. So, in a fee-for-service system, physicians are incentivized to do things. Now, you can argue that's good, because the more, in a system where the more you want, the more you get, okay. it incentivizes people to be available. So again, when I was in practice, my staff would come up to me and they'd say, Dr. Schuster, Mrs. Jones called, she's got a bad cough, your schedule is full today, the only time that you could see her is your lunch time. Would you see her? And I'm paid fee for service. That, in those days, $25 visit was $25 extra to me. My costs were fixed. I said, sure. If I was paid a salary, what would I say? No, I have to have my lunchtime. Okay. All right, now, so in this system, the primary care doctors are paid fee for service. So what does that do? That's the family doctors, the internists. What does that do to their relationship with their patients? What do you think?
They can't practice the medicine they would really like to, probably.
Some of them won't like it. That's correct, okay? But what it's going to do is it's going to incentivize them to be available. Okay? You want to see me today? I'll see you today because I'm gonna get paid if you come in. All right? So in a fee-for-service system, you're incentivized to deal with volume. And it's a low cost. You know, office visit today is what? $60? I don't know. Okay? What, 100? Depends, okay? Depends, okay? But
How much
it's,
we pay or the insurance pays?
Right.
yeah, right.
Is usual
okay.
customary or what's paid?
Okay, but the thing is this, in primary care, the fees are relatively low, whereas in specialty care, the fees are higher. So in France, the cardiologists are salaried. So when you go to see a cardiologist in France with chest pain, he or she is going to make a decision based on what they think are the indications for the disease process, and it will not impact their income. They may have to work harder, and that's an issue, right? So salaried people will make decisions that may result in them working harder, okay, or not working harder. So if you see a salaried doctor who's lazy, they're going to deny you care. Okay, that's the downside to that. The net out of all this, however, is that you have a system that's pretty efficient, where the expensive doctors are paid a salary and their decisions are professional, and the less expensive doctors are incentivized for volume to be available to people. It's a system that actually works very well.
Is there a check on doctors to make sure they're?
Okay, is there a check on the doctors? And this is critical, right? What's the quality like? What's the service like? Is it fair? Does it work? And that's where the government comes in. And in France it works, to make a long story short. That's why it's number one. They allocate their resources very, very well. Is it perfect? No. I've got colleagues in France, you ask them what it's like, they say it's a huge headache, because everyone always complains. Healthcare's in a crisis. Everywhere, all the time. Okay? Right?
Mm-hmm.
Okay? The system is a mixed system, so it's not owned by the government, but it's highly regulated by the government. People pay through their taxes. Bob?
And the taxes themselves, what kind of taxes are covered this? Is it like income tax, a VAT tax, or property tax?
So, the first answer is, I don't know.
Okay.
My guess is, and this is the way I look at it, you can charge people through all sorts of different kinds of taxes. It all goes into one big pot ultimately, and then it gets sent back out by the government. So whether it's a lottery that brings money into the government budget, or whether it's a VAT, or whether it's income tax, it's all going to the government to be reallocated. There is a big VAT in value-added tax or sales tax in France. There are high income taxes. There's a lottery.
Okay. The reason I ask is because in this country, the way it's financed is basically a variation of a VAT tax, in that the cost of the insurance or the salary that's paid is added into the cost of the product.
Right.
So when you buy a car, you may be paying $400. The value of that car is for health insurance.
Yes. Yes.
So
and that's, our system, as we'll talk about next, is really complicated, okay? And that's one of the reasons, is that we have different taxation, different government, making different decisions about spending different things. So your local government doesn't really provide health care for you. If you're on Medicare, it's federal government.